A very good morning to all of you and to all the doctors present over here. I would like to welcome all of you on behalf of Diabetes Research and Welfare Association, DRWA, on its third annual conference.
Good morning. Thank you, Pariniti. I am honored to address this August gathering, and I take this opportunity to welcome you all to Calcutta for our third annual conference. We are fortunate enough to have such an August gathering and a learned audience. I hope that Diabetes Update 2015 will enlighten us about the various case scenarios which we face every day. Our organization main motto is interacting, sharing and learning, and probably today we will do the same during our day-long program. We are privileged to have speakers of repute from all over India, and I take this opportunity to thank them all for accepting our invitation and readily agreeing to be here amongst us to share their experience. Today we are going to start our scientific agenda with two symposiums on two different molecules. One of them is an indigenous, make in India product, that is dual pepper agonist, saroglitazar, which has been hogging the limelight in both AAC and AADA 2015. And to speak on that, we have none other than Dr. Hemant Thakur, who probably needs no introduction. He's an eminent physician and diabetologist from Breach Candy Hospital, Mumbai. I welcome you, sir. And the next molecule which we are going to discuss is another new and interesting therapy for type 2 diabetes. That's the SGLT2 inhibitor, canagliflozin. Dr. Kausar Usman from KG Medical University, Lucknow, will highlight on this new avenue in diabetes treatment. I welcome you as well, Dr. Usman. Thanks. After these two symposium, we are not going to break for tea. Rather, we will continue with the long case presentations, and we have number of them on diabetes and comorbid conditions, which will be followed by interesting short cases. I sincerely thank our other speakers, Dr. Subrato De. He is a pediatric endocrinologist from Apollo Hospital, Kolkata. Dr. Anjan Siotia is a consultant interventional cardiologist at BM Birla Heart Research Center, Calcutta. Dr. Subrato Pal, he is a senior gastroenterologist from Kothari Medical Center, Kolkata. Dr. V.K. Bhartia, a very known face, a metabolic surgeon from Calcutta. He is attached to almost all the nursing homes in Calcutta, the big ones. Then we have Dr. Anand Sankar from Patna. Probably he is very visible nowadays, so he needs no introduction. And Dr. Sambit Das and Dr. Behra, who is coming from Bhubaneswar, probably they are not yet landed, or they must have landed, they are coming to the HHI directly. They are both from Bhubaneswar. Dr. Sambit Das is a consultant endocrinologist from Apollo Hospital, Bhubaneswar, and Dr. Behra, consultant endocrinologist from Kalinga Institute, Bhubaneswar. So what we are going to do is we start the scientific just straight away, and our first symposium will be on saroglitazar.
Good morning, ladies and gentlemen. Sunday mornings all over India are the same, and especially for doctors like us. You know, nobody realizes, neither the politicians, nor the patients, nor the community, that we as doctors are the only profession that are on call 25 hours a day. We get calls in the middle of the night, we get asked in a party, even in the lift and in the bus and in the taxi, you're always being consulted. So that's one day that you have, which is on Saturday night, to drown your sorrows or drown your problems. So CMEs on a Sunday morning in Bombay start at 12. And I'm sure Calcutta, which is the city which has the best soul in the country, also would start late. So I think it's happy to see that there are so many people here at 11 o'clock on Sunday morning, despite the fact that you have so much fun and so much food on a Sunday and Saturday here. But all the fun and the food is going to translate into problems for all of us, including our patients. And my motto today is to talk about a new molecule that has been making waves and that we researched on over the last decade, and that is saroglitazar, which is used for diabetes as well as dyslipidemia. Now, this molecule was launched about 2 years ago, and I'm going to take your hand and take you through a clinical journey of this molecule that we have successfully used in multiple conditions. I must point out that death rates in coronary heart disease, as you can see all over the world, has decreased. If you look at UK, if you look at Hungary, and if you look at the different countries in Europe, the death rates have gradually come down. And if you saw the Times of India 3 days ago, that too showed that the incidence of coronary artery disease in the US is also decreasing. Strangely enough, in our country, coronary heart disease deaths are still on the rise. And you can see from 1990 to 2020 what we have forecast, 2.5 decades, and we are still climbing. And it is this that is worrisome for our patients, for us, and for the generations to come. Now, this increase in deaths is because of a double jeopardy. One is the nature. Unfortunately, Indians have a genetically mediated constitution which needs to be sorted out, but which cannot be. So we look at nurture, which is lifestyle, which is sortable and which we need to sort out. We have urbanization, mechanization, our diet. It's not the Saturday diet alone. It's the daily diet. And we eat 4 times, probably 5 times a day. Physical inactivity. Tobacco, either we paste it, or we chew it, or we smoke it, or we inhale it, but tobacco is on the rise. And unfortunately, a lot of unenlightened physicians have clinical inertia, the inability of wanting to change and adopt a new molecule which can strike the right number. So all this put together we will show you in this presentation that if you separate this ship, it is non-HDL. I made this slide when Congress was in power 2 years ago, and that was the hand of God. Now, of course, the ship has sailed and the hand has remained because we have a different government in power. But for the lipid profile, it is the non-HDL segment which we really need to tackle. If we look at the prevalence of dyslipidemia in the general adult population, a study in 2014, you can see that we really do not have so many problems as far as LDL, but we have a lot of problems with HDL, which is low, hypertriglyceridemia, which is high, and LDL, which is high but not like the West. This is the typical Indian gene. And in India, if you look at the diabetic, almost 9 out of 10 diabetics have dyslipidemia, with 86% males and 98% females having hypertriglyceridemia. And as I said, the Indian dyslipidemia is different from its Western counterparts in terms of lipid parameters, where the LDL is small, the triglycerides are elevated, and this forms atherogenic dyslipidemia. Hypertriglyceridemia has now been proven to be an independent cardiovascular risk factor. And for every increase in TG level of about 90, the CVD risk increases by 35% in men and about 75% in women. However, the Indian is not bothered. Cholesterol is all that he looks at. He is not even bothered about other things. And though he is chased by diabetes, hypertension and lipids, he still thinks he can rule the world. So should triglycerides be the target to reduce cardiovascular risk? We've seen that non-fasting triglyceride levels and ischemic heart disease have a direct correlation. Higher the levels, greater the hazard. Lower the levels, lesser the hazard. There is this study which was seen, an original article in the NEJM, where participants with non-fasting triglycerides of less than 90 had 60% lesser risk of CV events compared to participants with non-fasting, which had more than 350. It is important to look at the term non-fasting. The world over now, everywhere, they are looking at random checks. Patient walks into the clinic. You don't want to create an artificial situation where you make him fast for 12 hours, because that's like going to the tailor, putting your tummy in and giving measurements. You'll get a wrongly stitched suit. You've got to see lifestyle. You've got to be hands-on. It should be real time. Again, the Lancet in August 2014 showed the correlation between triglycerides and cardiovascular disease, which was absolutely linear for myocardial infarction and ischemic heart disease. So, with all this, do we still have miles to go to treat the triglycerides? Let me say, in India, we still have a distance, but no more since we launched saroglitazar. Why in India? Because of our lifestyle and genetic factors, the nature and the nurture. Our diet is dyslipidemic rich, our physical activity, our genetic factors, our constitution, shorter height, lower BMI, excessive central obesity, abdominal obesity, truncal adiposity, and less lean body mass. So if with all this, we have a fat chance of getting to target just by exercising and diet, these patients definitely need some medication, because hypertriglyceridemia has a direct correlation with insulin resistance. And insulin resistance, if you look at stage 1 with normal glucose tolerance, where insulin resistance picks up, gradually goes into impaired glucose tolerance with proper diabetes, with micro and macro angiopathy, and it is increased triglycerides, low HDL, which causes the lipogenesis, obesity, waist-hip ratio. It's a vicious cycle, metabolic syndrome. And we can see that dyslipidemia and insulin resistance are, however, modifiable. One of the biggest factors which are modifiable. The diabetes burden in India, I don't want to give you figures, is increasing every second as we speak. Remember, as triglycerides come down to less than 100, the LDL becomes large. It doesn't become small and dense. So if you bring the triglycerides down, the LDL also is acceptable. So we have to do something more for our patients. And let's see what we can do for our patients more than statins. We know that if we stimulate PPAR alpha for lowering triglycerides, we can reduce both macro and microvascular complications. And that is with the help of phenofibrate, PPAR alpha stimulation. So they came up with this molecule, saroglitazar. If I was in Gujarat, I would call it saroglitazar, because in Gujarat and Gujarati, saro means good. So amongst all the glitazars, they found this to be good, so they called it saroglitazar. This molecule was conceptualized, inceptualized, and delivered in India. The journey is of 15 years, from 2001 to 2013, and now we are in 2015, the world's first approved dual PPAR agonist, which acts on alpha as well as gamma. It's a 1,000,000 ton